wanna settle that scar, but you're bruised and beaten, and you feel defeated. This goes out to the heaviest heart. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over, yeah, whoa. Yeah, whoa. Oh, game, set, match. Time to put it in your past. Oh, feel the winds are leaving. It's redemption season. Long live the young and high. Here's to a brand new start. We're revived and breathing to live a life of freedom.
Good afternoon. Thank you for joining us. The Latin American team from Young Epilepsy section is pleasure to welcome our speaker, Dr. Miserocchi. Professor Miserocchi was appointed at the National Hospital of Neurology and Neurosurgery, Queen's Square, London, as a consultant neurosurgeon in 2015. She completed her surgical training at the University of Milan, and she spent her last period of training at the Niguardia Hospital in Italy. She also completed 3 months of epilepsy fellowship at the Cleveland Clinic. Her main interests are epilepsy surgery and functional tumor surgery. Today, the learning objectives are demonstrate working knowledge of indication from presurgical evaluation, describe the importance of early surgical intervention regarding neurodevelopmental, cognitive, and behavioral social integration aspects, demonstrate working knowledge and etiologies amenable to surgical treatment and the prognosis in all age groups, and identify situations which require consideration of repeat surgery. Finally, demonstrate the value of need and multidisciplinary teamwork. It's a pleasure to have you, Professor Miserocchi. Welcome.
Thank you very much. Good evening or afternoon or morning, depending where you are. I'm going to talk today about surgical techniques in epilepsy. Now, the first slide is just to show you that historically, I think mainly all the doctors had understood that whenever there was something wrong in the brain, they had to try and get access to it and try and damage the brain in some ways. And I found this picture today, which I thought was very interesting. It was one of the first instruments that was used to do a lobotomy for psychiatric surgery. And it was published on the Lancet. And this is an improved version of the tool in itself. And I think the improvement was that, they could damage the brain, not just moving the whole device, but pulling this trigger and having the tip of the device that was moving up and down. Now, clearly nowadays surgery has changed a lot, but there is one main concept about epilepsy surgery, which is that you can offer an operation only when you have a number of data that are all pointing to the same part of the brain being responsible for the epilepsy. And that area is called the epileptogenic zone. So all the patients who are considered for epilepsy surgery, they have to go through a number of pre-surgical investigations. So they will all have an interictal and ictal EEG. Their seizure will be recorded on the video telemetry unit, and that will show you the symptomatogenic zone. If you're lucky, on the MRI scan, you might see a lesion, which is what we would call the epileptogenic lesion. And all the patients pre-operatively are going to go through a neuropsychological assessment. The main reason is that the epilepsy per se can damage some of the functions on the brain. And it is important to know what functions are diminished or damaged, because it might be an indication for where the seizures are starting from. Typically, for example, patients who have dominant temporal lobe epilepsy would have a verbal memory deficit, while patients who have non-dominant temporal lobe epilepsy will have visual memory issues. The vast majority of epilepsy surgery in adults is lesional surgery, and we can find on the scans a number of different abnormalities, some of which are more common than others. I'm going to show you some of the most common radiological appearances. I'm sure you're all familiar with hippocampal sclerosis, malformational cortical development, tumors, vascular malformation, and other lesions which are less common. This is probably the pathology that we find more often in adult epilepsy. So you're all going to be able to recognize a sclerotic hippocampus on the left side, which looks smaller on the T1 images, and it looks brighter on the FLAIR sequences. Now, these days, we don't just rely only on a qualitative analysis of the scans, but we like to run a specific software to have a quantitative analysis of the hippocampus. And the reason why this is helpful, it's because sometimes, what fundamentally the radiologist is doing is comparing on a coronal image left to right. And in this case, it is clearly very easy to see that the left one is smaller than the right one. And this is an example of the quantitative analysis. So here you have the mean volume of the hippocampus. The way the graph is read is that this is the tail, this is the length towards the body, and this is the head of the hippocampus. This is the standard deviation of the volumes of a number of normal hippocampi. And here you can see that the hippocampus of the patient is clearly below the mean of a normal volume, and the T2 signal is higher than a normal volume. The right one, this dotted line, is perfectly normal, and a comparison right to left sided hippocampal sclerosis. The reason why this is important is that sometimes you might have that actually both hippocampi are small. So if you're trying to find a pathology, you may think that there is no same, but actually, like the example of this patient, you can see that both the left and the right one, they're equally small in volume. And this is important because it might change the indication for your surgery. You may think it's non-lesional, but actually you might have pathology on both sides of the brain. Whenever it comes to malformation of cortical development, there are mainly three groups. There are group number one, where there is an abnormal proliferation of neuronal and glial cells, and this is mainly represented by focal cortical dysplasias. Group number two, where there are malformation resulting from abnormal neuronal migration, and group number three, where the malformation are resulting from an abnormal cortical organization. Now, not all of these malformations are strictly surgical, but I thought it was nice to show you some of these examples. This is another very common abnormality in epilepsy surgery and belongs to group number one. So there is an abnormal proliferation of the neurons. And this is a type of focal cortical dysplasia, which is often very visible on flare sequences. And here you can see the abnormality that strides often between the sulci and tends to have a tail that goes towards the ventricle. Now, it's very important when you ask your radiologist to review some of these scans that you give them a bit of a context of the epilepsy of the patient. This dysplasia is quite visible, but sometimes are very subtle. So it's important if you're looking for, you think the epilepsy is coming from the occipital area or the temporal area, that you tell them that you think where the epilepsy is starting, so they can keep more of an eye on those areas and look for subtle lesions such as dysplasias. This is another group of abnormal cortical neuronal migration, and you can see fundamentally that the patient has gray matter when there's not supposed to be any gray matter. So these are all ependymal nodules here and here. And this is a band heterotopia where you see a band of gray matter within the white matter. You see the left side here is normal. This is a patient in which that has an abnormality which is called lysencephaly. Lysos in Greek means smooth, and you can see that the cortex lacks most of the gyri and lacks most of the differentiation between the gray and the white matter. And the last group are patients who are having an abnormal cortical organization, and this is one of the examples in which the patient has a cleft in the brain, which is called schizencephaly. Schizos in Greek again means to split something. The other group, which is very common in adult epilepsy surgery, are tumors. And this represents about a third of the cases. Now, as you might know better than me, because I think most of you are neurologists, a lot of brain tumors, high grade, low grades, they do present with seizures. But what we see mainly in epilepsy surgery are a specific group of tumors, which are DNTs and gangliomas. These are tumors that, strictly from an oncological point of view, they tend to be quite indolent. They don't tend to change too much throughout the years, but they can become very easily resistant to the anti-epileptic drugs. So the indication becomes more not an oncological indication, but an epilepsy indication. Here is an example of a DNT that you can see it tends to be bubbly and hypo-intense on T1 images. and it tends to be hyperintense on flares and T2s. It's very usual that the DNTs can be quite diffuse. They're not just confined to the cortex, but sometimes you can see some nodules that extends in the white matter. From an epilepsy surgical point of view, what you need to remove in these patients is mainly the areas that are affecting the cortex. So in this patient, there would be no need to chase this tiny little dot in the white matter because it is unlikely that that would be the source of the epilepsy. The other tumors that are low grade and tend to become resistant to antiepileptic drugs are gangliogliomas. Now, gangliogliomas have a bit more of a tricky appearance, and sometimes they might be mistaken for higher grade tumors just because they tend to enhance. They tend to have a solid nodule and a little cyst associated with it. And as you can see, this is a contrasted scan and the nodule is avidly enhancing. As I said, sometimes they can be mistaken for high-grade tumors. This is a young lady that presented to us with actually seizures that were not recognized for quite a period of time. Now, you would say it would be very easy to say that this could be a high-grade tumor. The only thing that made us preoperatively thinking this might be something else, as you can see, the bone here is completely scalloped and sort of indicates that it has been accommodating a lesion for a long period of time. Whenever it comes to vascular malformation, what we tend to look after as epilepsy surgeons are cavernomas. Also, arteriovenous malformation can give epilepsy, but they're normally dealt with by vascular surgeons. What it is important and is mainly different if you're approaching these cases as an epilepsy surgeon rather than a vascular surgeon is that the epilepsy is thought to be rising not from the cavernoma in itself that doesn't have any neurons within it, but from the hemosiderin stain surrounding the cavernoma. So it is very important that in your imaging setup, you do have sequences such as the T2 sequences or the SWI that can show very nicely the ring of hemosiderin surrounding the lesion. And this is another abnormality that we are trying to see, I think, more often these days. I think probably because the scans are getting better and because our eyes are trained a little bit more to look for it. And this is what it's called an encephalocele. So you have a very small amount of brain which is protruding through a tiny hole on the anterior skull base. And encephalocele can be in the temporal fossa or can be on the anterior fossa floor. Always look, whenever you have this type of abnormalities, that there are no other images features of raised intracranial pressure in the brain. The theory behind it is that sometimes the fact that the brain is protruding is because the patient has an unknown level of raised intracranial pressure. Other signs that you might find in patients with encephalocele are an enlargement of the ventricles, and the CSF spaces, which is disproportionate for the age of the patient. They might have an empty cella, and they might have dilation of the optic sheath. Like in this case, you should not be able to see this T2 signal change around the optic nerve. And these are all signs that the intracranial pressure isn't normal. And this is how an encephalocele looks preoperatively. So once you remove the cortex, which is protruding, you see two tiny holes in the anterior fossa floor. This one that you can see here is the tip of the pointer that we use for the navigation. And you can see that the tip is in the hole and is nicely indicating on these scans that I am exactly in the area where there was the encephalocele. And this is the same patient that I showed you at the beginning. And look what happened after the operation, because we probably didn't give enough weight to the fact that there was these signs on the scan of raised intracranial pressure. She developed a huge amount of complication due to CSF dynamics, and it took quite a long time before we were able to get on top of this. So whenever it comes to lesional epilepsy, the literature is plenty of one simple concept, which is you need to be able to resect the lesion in its entirety to give the patient the best chances of becoming seizure-free. So throughout the years, one of the things that has changed a lot the approach to this lesion has been the advent of the interventional MRI. Now, here is how the theaters used to look at Queen Square when Victor Horsley did one of his first operations in epilepsy. And this is how the theater looks like these days at Queen Square. So we have an MRI magnet within the premises of the operating theater. And the advantage is that when we think we have removed the lesion in its entirety, we can stop, rotate the table, and the patient acquire some intraoperative images. And this is one of the first studies that came out from a German group when they used intraoperative MRI. And they showed that in their patient, 25% had an incomplete resection, and they had to go back and remove more of the lesion after the first intraoperative scan. And here you can see how easy it might be to forget to take something. Like this temporal resection is outstanding. It's very good. They've gone all the way to the mesial structures. And there's just a tiny nodule of lesion which has been left behind. And, you know, if you do a post-op scan the day after, sometimes it's a little bit more difficult to identify this small residual. There is brain shift, there is a little bit of blood in the cavity, and you may not see it. And the reality is that if the patient doesn't become seizure-free and you repeat a scan in 6 months, then you might be able to see what you've left behind, and you may have to do a repeated craniotomy. And clearly the interventional MRI has given a great advantage from that point of view. Here is one of the cases that we did recently at Queen Square. There is a patient who had a previous resection for a temporal tumor. The tumor had recurred. And this is just to show you the amount of residual that we left and that we were able to identify within the interventional MRI and go back and resect exactly at the same time. Another greatest advantage of the surgeons today is that we're able to project on our scans functional images and tractographies. So we're able to see where are the functions located in relation to the lesions that we want to remove. This is a young girl who had epilepsy for quite a long period of time before presenting to us. And we did some tractography, and we were able to see that, you know, the corticospinal tract was just displaced laterally in relation to the lesion. And we did the resection of the abnormality, and you can see that the corticospinal tract was beautifully preserved at the end of the operation. Now, this is something that is very reassuring for the surgeon, because this lesion was mainly located in the supplementary motor area, and she developed acutely on the table a supplementary motor area syndrome. So she was completely unable to move the opposite side of the body. And, you know, if you do not have the reassurance that your corticospinal tract is intact, you may think that you have damaged it. The other tool that has quite given a great advantage during surgery is that not only you can see your tractography on the scan, superimposed on the scans, but you can also see your tractography projected down the microscope eyes. And I'm going to show you why this is important. So when we do temporal lobectomies, this is a schematic draw, but one of the problems of the surgeons is that to get to the hippocampus, we need to get inside the temporal horn of the lateral ventricle. And part of the optic radiation, which is called the Meyer's loop, is wrapped around exactly the area where we want to go. This is a beautiful cadaver that shows the Meyer's loop here. Now, unfortunately, when we're doing the operation, it doesn't really look like this. Look, the white matter looks all the same. So you will not be able to tell where is the Meyer's loop. And the reason why it's important to try and spare this function is because if you give the patient a visual field defect, the patient may not be able to drive in future, even if they become seizure-free. So the concept for us was quite easy. We ran a number of patients in which we did the tractography, and if we managed to do the resection in front of the optic radiation, we should not be expecting a visual field defect. While if we do the resection and we cut off part of the optic radiation, we would expect the patient to have a visual field defect. And the problem that we have is that this loop, it's very variable in terms of distance from the temporal pole. And that's why it is important for us to be able to visualize it and make it patient specific. And this is how it looks during the operation. So this is a right-sided temporal lobe. The Sylvian fissure will be up here. And here now you're going to see, in a second, you're going to see the ventricle. There are some lines here. This white line represents an outline of the ventricle, which is going to be open now. And this is the hippocampus here. And this other outline represents the optic radiation. And you can see that what we're going to try and do is to do our resection but stay anterior to these projections. So now I've taken away the temporal pole, but I haven't touched the optic radiation in itself. And this is an intraoperative scan again. And we managed to do 21 consecutive patients in the interventional MRI, and we managed not to give a single visual field defect that would prevent them from driving. While before, we used to have at least 10% of the patient might have failed the driving criterion. So this one was the first part of the talk, in which we've seen mainly lesional epilepsy. What are the commonest lesions and what can we do to make surgery safer, which is interventional MRI, tractography, and integrating the tractography during surgery. Now, the second part of the talk is with regards to when we can't just go straight to surgery, but we need to do something else to identify the area which is responsible for the seizures. So there are a number of patients in which, despite having the video telemetry, the neuropsychology, the MRI, and everything prepared, you are not able to identify which one is the epileptogenic zone. This is mainly because all this data may not be entirely concordant, or because you may have everything pointing to the same part of the brain, but your MRI scan is fundamentally negative. So you can't just go and chop everything out. You just need to prove that that area is responsible for the seizures. In these categories of patient, what you need is a diagnostic procedure, which is called intracranial electrode recording. Now, historically, there have been two schools that have been going on separate pathways for quite a long time, up until the last probably 5 years. So the American and English school has been mainly concentrating on using grids and strip electrodes to cover the surface of the brain. The French and Italian school was more using a different approach, which was inserting electrodes in the depth of the brain. Now, over the past 5 years, probably, there has been a large uptake of the stereo EEG, even in parts of the world where before it was mainly grids and subdural strips. And the reason I will explain you later, but fundamentally you can do different things with the different approaches. And even when it comes to exploring the brain with grids or stereo EEG, we try and help ourselves with 3D multimodality imaging. So fundamentally reconstructing the patient-specific data in a 3D model. This is a patient who had a focal cortical dysplasia. It's quite subtle in this case. It's here and it's located in there. But I think the reason why we decided to implant is because, first of all, it was quite close to eloquent areas, as you are going to see in a minute. So this is where the dysplasia is sitting in relation to the rest of the brain. Here you can recognize the motor strip. This is the sensory strip, and this is probably the hand motor area, which is confirmed by the projection of the functional MRI. You can see where the verbal fluency is appearing and the verb generation. This was the ictal spat, which was much larger than the lesion in itself. And also these days we can manage to have a beautiful representation of the vessels on the cortex of the brain. And this is the approach that we used. We decided to cover the area of the brain with a large grid and having some depth electrodes that were going through the lesion, which is sitting pretty much in this area. And this is just to show you how accurate is these days, the representation. This is all an image that is done pre-operatively with a specific MRI scan, but it just beautifully overlaps with what you find during the operation. This is a reconstruction of the grids that we've placed. And this is why sometimes it's still helpful to have the grids. I do 15% grids, and all the rest, 85%, is actually done with stereo EEG. But in this specific case, so operatively, beautifully where hand motor is, and actually the ictal onset was slightly more anterior than the lesion that we were projecting here, and the patient went ahead and had a much larger resection than just the abnormality per se. Whenever it comes to stereo EEG, it's important that you cooperate with your neurologist a lot. This is because, we have different needs from what you have. So whenever you're planning a stereo EEG, you want to know, I think the ictal onset is here, but then I want to know the spread, and I want to know all the area that are close to here. I want to be able to map, etc., etc. But this is the way the neurologist looks at the brain. So, you think it's temporal, it might be orbitofrontal, so you want something going in there. But for us, the surgeon, this is what I see whenever I have to plan an electrode. So the brain is heavily vascularized, and we need to make sure that our trajectory are safe. So you always have to reach a good compromise with your neurologist, that you have enough electrodes to achieve a diagnosis, but that you also have a number of electrodes which is safely implantable for the patient. And the different ways these days of putting the electrodes in the brain for a long time has mainly been manual. So the patient had a stereotactic frame, and the electrodes were put in with a guide of the stereotactic frame. These days, most of the groups are using robots, and they can be big robots like this one or smaller robots. And this is just an example on how the surgery works. So this is a smaller version of the robot that we have been trialing at Queen Square over the last couple of years. And all you need to do is a little bit like playing a video game. You have to put the robot roughly in the trajectory that you've planned the electrodes, and then you lock it, and then you see here there is someone that pressed the button, and your robot moves exactly on the pre-planned trajectory that you've made, and is beautifully aligned in a matter of seconds. So the procedure is quite repetitive. So fundamentally, you put all the bolts before, and then you make, all the bolts for all the electrodes. And then you normally have a little stylet that goes down each one of these trajectories. It should come in a second. This is the bolt going in. Here we go. So you make a little track for each electrode with this stylet, and then you remove the stylet, and then you place the electrode. So one of the things that is very different when you do stereo EEG, that often you end up having a target for your resection, which is not on the surface of the brain, but is deeply located in the brain. And having this 3D reconstruction is very helpful both for the neurologist to understand how the seizures are spreading, but also for the surgeon to be able to understand how to plan the operation. And here is one of the cases that we did. So the epilepsy was exclusively coming from the mesial prefrontal cortex. So we had the model of the brain, and we designed what we wanted to take out. And then we did, again, the operation in the interventional MRI. The reason being, you might find this a bit unusual because you say, well, the MRI is negative, so there isn't really a lesion to take out. But what we do, we give ourselves some targets that we want to take, and these were marking the electrodes where we found the seizure onset, and we make sure that before the patient comes off the table that we do a scan. And then here you're able to see that the electrodes that we wanted to remove, they're fundamentally floating in the air. So it's a way to make sure that you have completely resected what the neurologist wanted you to take out. This is another example. This patient had way more electrodes, but here we have highlighted only the electrodes where the seizures were coming from, and we have highlighted preoperatively the area that we wanted to take out. And it's really important when you're doing these resections that you spend some time at the beginning of the operation to try and identify the holes of the electrodes that you've planted on the cortex, just because that is going to give you a really nice idea of where do you need to resect. Here you see, like, I've marked the holes for you, here, here, and here. And again, I just wanted to show you one more time how beautifully the pre-op reconstruction of the vessels matches what you find intraoperatively. And this, for the surgeon, is very reassuring, because if you lose your navigation, you can navigate safely out of the pictures that you have done before the operation. So this was the end of the second part. So we have discussed when do you need intracranial electrorecording and the two different techniques and when you should use one or the other. Now, in the last part is a little bit more about alternative to resective surgery. And the first technique that I want to show you is the laser. Now, this technique has been in use in the US for the past probably a little bit more than 5 years. And the operation per se, it is very similar to the insertion of the electrodes that I've just shown to you. And what this technique does is that you insert, you pass a catheter down the brain, and on the tip of the catheter, there is a small laser. And what the laser does, creates a sort of thermal ablation of the surrounding tissue. So again, the principle behind it is the same. So you need to have a lesion. You need to have a target, a very clear and specific target, and you need to be able to reach that target safely with your catheter. Once you place the catheter, the patient is, again, in an MRI scanner. And within the MRI, you can check the amount of thermal ablation that you are producing. So here an example, you see the laser goes into the hippocampus, then you scan the patient to make sure that your catheter is in the correct position. And then, there are specific parameters, and that helps reaching the correct temperature for the target. This is one of the example in which you can see the catheter that goes straight into the mesial temporal areas. Now, you can ablate most of the lesions with the laser. I think for some of them, you do have safe and sound surgical approaches if you do not have these techniques. I think this tool will revolutionize the treatment of one specific lesion, which are hypothalamic hamartomas. The reason being that hypothalamic hamartomas are incredibly difficult abnormalities to reach within the brain. And surgical treatment carries an incredibly high morbidity. And the problem that you have that these lesions are not very common. So acquiring a large surgical experience of them, it is very difficult. And this is the result of one of the papers that was published where they had like eight patients, hypothalamic hematomas, and they reached 6 patients became seizure-free. 1 patient had a 75% seizure reduction, and the amount of surgical complication was extremely low. And they collected some of the papers that were out there, and they confronted what were the chances of becoming seizure-free with the laser, with gamma knife radiosurgery, and with open surgery. And there is a clear win towards the laser ablation that has a very short length of stay in hospital, very low morbidity, and incredibly good results in terms of seizure freedom. You can see 85% of the patient was seizure-free, while 50% were with a gamma knife and 50% with open surgery. Now, what is gamma knife, which I've been mentioning a couple of times by now? Gamma knife is a specific type of radiation. And again, in mesial temporal lobe epilepsy, just because you have a very specific target and you enrich the target and destroy the target with radiation. The gamma knife is performed putting a frame on the head of the patient, and it's done under local anesthetic. So the laser is done under general anesthetic. Any temporal lobectomy is done under general anesthetic. The gamma knife is a day case procedure. So the patient comes in the morning, gets the frame on the head. There is about an hour and a half of planning. And then the patient gets inside the machine, which is very similar to an MRI scanner. And the treatment lasts about an hour and a half. By the end of it, the patient comes out, the frame is removed, and the patient goes home on the same day. There's no cut on the skin, there's no general anesthetic, it's a day case procedure. I mean, clearly you think you will be choice number 1. So there has been a very big trial, which was the ROSE trial, in which they did randomize the patient towards open surgery for mesial temporal sclerosis or gamma knife for mesial temporal sclerosis. And this is one of our patients. I just want to show you what happens when you give the gamma knife. It's a clear-cut hippocampal sclerosis on the left-hand side. At 10 months, you see this is a very typical reaction to the radiation. So the lesion that you have treated gets bigger, gets a little bit of edema around it, and the enhancement is normally due to radionecrosis. This is what happened in 1 year. There is even more radionecrosis and even more swelling around the treated area. And this is what happens at 14 months. So again, if you don't tell your radiologist what's the history of the patient, even if you show this scan to me these days, if I'm on call overnight, you give me the scan, I would think this is a glioblastoma up front. There is mass effect, there is enhancement, there is an enormous amount of edema. But look what happens a few months later, where you had the hippocampus, there is a tiny little hole, there is no longer swelling, and the mass effect has completely resolved. So what were the results of the trial? So the first and major difference between open surgery and gamma knife is that with open surgery, you're fundamentally seizure-free from the day after the operation. So you see at 3 months, only 6% of the patient who had gamma knife was seizure-free, while 81% of the patient who had open surgery was seizure-free. And the other thing that became quite obvious is that patients react very differently to the radiation. So there's not really a time that is the same for everybody. They would all get different reaction, and it's difficult to tell them when they're going to become seizure-free. And there was no doubt that actually the patient who had open temporal lobe surgery did better. However, the result was not significantly different. One of the reasons why they wanted to try the gamma knife is that the thinking behind it was that if we do not have to resect part of the temporal lobe to reach the hippocampus, we would think that the impact on the verbal memory or the visual memory would be less. But they were not able to find that result. So again, what happened, those who had surgery, they had an immediate decline in their memory, which was a lot worse compared to the group who had gamma knife. But then over time, the group who had surgery kind of improved pretty much to the same level of the group who had the stereotactic radius surgery. And this difference might be due to the fact that the patient who had open surgery the chances of becoming seizure-free were a lot higher than the gamma knife. So we've seen now 2 techniques that potentially you can use if you want to avoid resective surgery. Now, there are clearly patients which, unfortunately, there's not really a target that you can go and remove. And these patients sometimes are offered a sort of palliative type of procedure, which is the vagus nerve stimulation. It's a very simple procedure. It lasts about an hour and a half. It's effective in about a third of the patients. Now, I don't think I ever seen anybody becoming seizure-free with a vagus nerve stimulator, but a lot of patient reports an improvement in seizure control in terms of the number of seizures or in terms of the intensity of the seizures. And quite a lot of them, especially the parents who are having kids that are very cognitively disabled, they report an improvement in the mood. So in the US, the vagus nerve stimulator is also, I think, is also used in patient with depression. It's not licensed in Europe for this. And again, it's a very simple procedure. You just need to wrap this around the vagus nerve. And the main indications are patients who are having multiple and bilateral independent foci of epilepsy, patients who are having generalized epilepsy, patients that have failed intracranial electrode surgery, or patients that you can't operate because the operation might be too risky. And this is another type of stimulation, and it's called the neuropace, and has the big advantage of being able to record and stimulate the brain at the same time. And again, a little bit like the VNS, if you have the right indication, might be a very helpful tool. And it's been mainly used in patients who have mesial temporal epilepsy that can be bitemporal. So clearly you can't remove both hippocampi, but you can try and stimulate down the hippocampi and achieve a better seizure control. Or it has been used in those patients who are having foci that unfortunately are in very eloquent neocortical areas. And in that case, no matter if you do a lesion with the gamma knife or with the laser, or you try and take it out, you would expect a neurological deficit. And for this patient, it's possible that you can actually stimulate the area and try and give them a better seizure control. And I think I have a couple of slides just to show you how effective can be epilepsy surgery. And this is it's a paper that came out from our group. So it's about just a little bit more than 600 patients. You can see that in adults, the vast majority of the epilepsy is temporal. So that was the largest cohort of patients. The follow-up was about 8 years, and you can see that at 5 years, 52% of patients were seizure-free, and at 10 years, 47% of patients were seizure-free. Now, you always have to put in context, whenever I discuss with some of my colleagues who don't do epilepsy, I say, well, you're offering an operation that have 50% chances of being effective. And you think it's not particularly good, but any drug, once you've tried 5 or 6 drugs, it only has a chance of making you seizure-free of about 2 to 3%. So surgery clearly is way more effective than that. And you can see that about a third of the patient were seizure-free and off medication. And what about the complications that you might expect? So here, again, this is a paper that came from our group, and it had a look at the somatic complication of epilepsy surgery over 25 years. And there were about 900 procedures and no perioperative deaths. And as you can see, the vast majority of patients as a complication, which is kind of expected, they had a quadrantonopia. And that's counts for about 10% of the patient. But all the other complications, so infection, hematoma, CSF leak, they're well within the range of what you expect from any neurosurgical procedure. And this is the end of my talk, and I hope that was helpful. And I'm open for questions now.
Thank you very much, Professor, for your wonderful talk. Please, I ask everyone to feel free to ask any question. Here, I have one question, Professor.
Yep.
About the complications of the visual deficit, what do you think could be the better pre-evaluation to avoid them?
So I think, first of all, so depends where if you're doing a temporal lobe resection, I think the best thing to do is a tractography. So you can see what's the relationship between the hippocampus and the optic radiation. It's important if you're doing surgery in other parts of the brain, like if your patient has, I don't know, an occipital lesion or something like that, I will also pair your optic, your tractography clearly with a visual field assessment. You know, sometimes the lesion might have been there for a long time, and there is already a visual field defect, and the patient may not be completely aware of it because he has been having it for so long that it's kind of become his normal vision. But for sure, the tractography for the optic radiation, that would be the most helpful tool to visualize where the white matter tract is passing.
Okay, here we have another question. Is the RNS a good option as a palliative option for those patients with no surgery indication?
Sorry, say it again. Would that be a? Can you repeat the question? Sorry.
Yes. Is the RNS a good option as a palliative option for those patients with no surgery indication?
VNS or? It breaks up a tiny little bit. He's asking me if the VNS is a good option. Is that correct?
Yeah.
VNS, yes. So RNS, okay. Is the RNS is a neuropace, is the same thing. So it is, again, you need to use the right tool for the right patient. So often the RNS is used when patients have bitemporal seizures or when they have an epileptic foci, which is in an area of functional cortex. So in these cases, it is effective. Now, some of the patient can become seizure-free, but you should not expect 100%, it's not as effective as when you can take the lesion out. But if you have the correct indication, it is a very helpful tool. Now, unfortunately, it's not CE marked. So in Europe here, we can't use it. And I suspect would be the same for quite a few countries outside the US.
Okay, thank you.
We have in our cohort of patients, some of the patients that are like, this would be the perfect indication for an RNS, and we're kind of stocking them up from where hopefully one day we're going to be able to use it.
Okay, thank you. Another one is, how often do you have a worsening memory in the post-operatory?
So, very good question. I consent all of my patients for a decline in their memory immediately after surgery. The reality is that some of the patients might notice more than others. So if you have, that's one of the other reasons why it is important to have a neuropsychological assessment before the operation. You want to know what is the cognitive reserve of the patient. So if you have someone who's, the memory is borderline and it declines a little bit, they may not notice a huge amount of difference. But if you have someone who's highly functioning and you give them a memory deficit, they will notice a lot more. And the other thing, there are some other patients that the memory is already so bad that if you give them a further cognitive deficit, they just, the outcome is disastrous. So the memory really gets a very big hit from the operation. So it's important to cooperate with your neuropsychologist and make sure that you know what's the level of function pre-operatively, what's the cognitive reserve. And it's very important to consent the patient, because there are these days, there are tools that can help, like, iPads, iPhones. You can sort of outsource your memory to this device, but you have to prepare them. And it's a very important thing, especially it's not very often, but we do see patients like over 55. Very rarely we do over 60s, but in these patients, memory is a very important topic in the indication. And I know our neuropsychologist always says that for some patients, like over 60, they say that, when you do the operation, their memory ages in about 10 years in the one day you're doing the operation. And some patients have regretted, they were seizure-free, but they say my memory is so bad that I have regretted having the operation done. So, the outcome is good when all the criteria is not just seizure freedom, the criteria is also quality of life. Any other questions?
Thank you. One more question. In your experience, Professor, what is the best surgical scale outcome?
What is the best surgical
outcome scale? The angel or
the angel or the... It's a fight that I leave to the neurologist. I tell you what, I think in future probably what it will become important as well will be integrating those scales also with the neuropsychology. So the outcome as it best is the patient who's seizure-free, off medication, and with a normal quality of life. And we do see occasionally patients who are seizure-free, but they got either very badly depressed or with a terrible memory. And, you can say it's angle one, but you haven't achieved a good quality of life for the patient. And I'm sure at some point it will come that those cases will be integrated with the functional outcome of epilepsy, memory, and psychiatry.
Okay, thank you. One more here. Does the blocked temporal lobe lobectomy still is the better than tailored temporal lobectomy in surgery outcome?
It's a very good question. I think for sure what I've noticed that we now do, we are managing to approach the mesial structures doing much smaller cortical resection. So, you manage still to preserve the neuropsychology and having a good seizure outcome. I think, the literature is still a bit controversial on this. You would have people who would be stronger advocate for selective amygdala hippocampeectomies. I'm not a particularly strong advocate for that. I think in a way, if you look at the result that you had with the gamma knife, when they were, targeting only the mesial temporal lobe, at the end of the day, the neuropsychology was very similar for both patients. So overall, I think you do have very good results with a standard temporal lobectomy, including temporal neocortex and mesial temporal.
Okay. And the last, how often is the running down syndrome present in patient after surgery?
What syndrome, sorry?
How often is the running down syndrome present in patient after surgery?
Running down?
Like,
I'm not sure what they mean.
how?
Sorry.
Okay, let's try to take another one. Okay, and what is your opinion about the relationship between epileptic encephalopathies and epilepsy surgery when you don't have a specific, for example, cortical dysplasia or lesion, but you have a epileptic severe syndrome?
Yeah. So again, the surgery for epilepsy, it's for focal epilepsy. So patients who are having diffuse processes, it's unlikely that they're going to do well with a tiny resection. It might be helpful for them to have things such as the VNS. But if you have a diffuse process in the brain, taking out a small part, you do not have a target. That's the problem. You don't have a target to go after.
Okay, thank you, Professor. I think there is no more questions. Once more, excuse me. About the last question, how often decline? How often you see decline after surgery in patients with surgery?
Decline in terms of memory, or
yeah.
So after we see a memory decline.
Yeah.
I would say so. Nearly all of them get a memory in decline. Nearly all of them. That if it has an impact or not, that depends on what we were discussing before: the cognitive reserve, how large is your resection. But patients are having, and sometimes decline can be also, if you're doing like a frontal resection, can be the speed of processing the information. So if you have a very accurate pre-operative neuropsychology profile, nearly all of the patient immediately after will have a decline. Now, in the longer term, if they become seizure-free, you reduce the medication, you may see that the neuropsychology improves again. Sometimes it can back to the same baseline that it was preoperatively. Sometimes you can see some gain, especially when the patients are seizure-free and off medications. And sometimes it doesn't really recover all the way. But if your tools to find neuropsychological deficits are very good, it's very likely that every operation would come with a deficit. It may not be impairing the patient to a large extent, but if you're good enough in looking for it, you would find it.
Okay. Professor, do you have any experience about the hypothalamic hamartoma with VNS?
With VNS, so I think we do have some patients who are having the VNS and a hypothalamic hematomas. It's not, it doesn't work great. They're not seizure-free. It might have changed a little bit the quality of the life, but it hasn't done a huge difference. I mean, overall, it's, I think sometimes it's just worth giving it a try. It's out of all the operations that you can do for epilepsy, it's a very low risk one. It lasts about an hour and 15 minutes, about an hour. And, you know, sometimes it's actually the parents of these kids, of the young patients that are asking for it. Like, we've tried all sorts of things. Can you just try and see if the VNS works? And they're willing to take that small risk. So, but I haven't seen great results, to be honest. I think if the laser will have a profound uptake, the main problem at the moment with the laser is the cost of the catheter. So each one of these catheters, I think, is about £10,000. But really, that would be an exquisite indication for hypothalamic hematomas. That really changes the course of the disease. You've seen when I showed that study, 85% of the patients seizure-free. It's unbelievable. Like, you will not achieve that with medications. You will not achieve that with a VNS. You will not achieve that with gamma knife. And surgery, it's incredibly risky. You know, it's a surgery for hypothalamic hematomas. They can have diabetes insipidus. They can have, you know, alter the body regulation of the temperature. They can have difficulties with regulating the amount of food they want to eat. It's a really difficult operation. It's very high risk.
Thank you very much, Professor. I think we don't have any more questions. Once more, thank you for your wonderful talk.
Welcome.
We hope to see you again in the webinars. Thank you very much.
Thank you. Thank you, everybody.
Thank you, everyone. See you the next webinar.
Bye. Bye-bye.
Bye-bye.